I'm one of the lead genetic counselors in the Smilow Cancer Genetics and Prevention Program, and I'll be helping to moderate this event. We're very happy to have you joining us. This is the third webinar in a series geared towards individuals with hereditary breast and/or ovarian cancer syndromes, as well as their family members. Tonight, we're pleased to welcome Dr. Avraham, a plastic surgeon, who will speak to us about options for breast reconstruction, Dr. Farrell, who will speak to us about risk for pancreatic cancer associated with some hereditary breast and ovarian cancer gene mutations, as well as options for pancreatic cancer surveillance, and Amy Killey, a genetic counselor, who will discuss risk for cancer in men with mutations in hereditary breast and ovarian cancer genes. Each of our speakers will present for approximately 20 minutes, leaving 30 minutes at the end of the session for questions and answers. Please submit your questions through the Q&A feature, which can be found at the bottom of the webinar window. And questions will be held to the end of all of the talks, and we hope to get through as many as possible at the end. So with that, I'll turn it over to Dr. Avraham.
Good evening. Let me just share my screen and get my PowerPoint up. All right, can you guys see? Somebody nod. All right. Okay, so today I'm going to talk about mastectomy reconstruction in women at high risk for breast cancer. I am the one person speaking today who cannot talk to you specifically about cancer risk, but an adjunct to it. And then just fair warning, this is plastic surgery talk, so there will be photos with before and after. So if anybody has a problem with photos of breasts, just fair warning. So just a brief outline, we're going to talk a little bit about background of breast reconstruction, how this relates to high-risk patients, what the reconstructive consult is all about, and how to figure out a little bit about your options, as well as some examples of women that have had reconstruction with implants and their own tissue. So mastectomy reconstruction is a very common operation. In 2017, the American Society of Plastic Surgery approximates that more than 100,000 women underwent breast reconstruction. The vast majority of those nationwide were implant-based reconstruction, with less than 5,000 being autologous, that is, using their own tissues. That's driven by a lot of things, including the fact that breast cancer is a common disease, and also some medical economic issues, and something called the Women's Health Cancer Rights Act of 1998. So the Women's Health Cancer Rights Act of 1998 specifies that insurances must cover mastectomy reconstruction, any surgery that's necessary for symmetrization by an unaffected breast, any revision surgery that's necessary, as well as prosthesis and special bras. So therefore, that creates an environment where breast reconstruction can be a very common operation. And then, you know, I obviously we have a limited amount of time, so I can't be comprehensive, but there are some issues that are specific to patients that are high-risk patients when it comes to breast reconstruction. For example, in this population, surgery may be preventative rather than therapeutic. That is, these women may not have breast cancer. Therefore, there may be less urgency, there may be more options on the table, and there are really a different set of psychological and emotional impacts that can be encountered. The patient population that we deal with that's high risk may be younger than the typical mastectomy patient, and again, that has lifestyle and psychological implications. There can be different body shapes, body types, and breast issues. And additionally, these patients may have risks for additional cancers, and as I'll discuss later, that can lead to some synergies and some coordination between surgical and oncologic teams. Some other considerations that are that nipple-sparing mastectomy, that's something that you guys may have heard about, and it's actually a very individualized decision whether to preserve the nipple or not, and it really needs to be made in concert with the breast oncologic surgeon that's going to be doing the mastectomy, and takes into account their technical comfort, the patient desires, and the anatomic realities of a woman's breasts. Breast risk-reducing surgery can also be combined with GYN risk-reducing surgery, as I sort of alluded to earlier, because a lot of the genetic syndromes that are associated with an increased risk of breast cancer are also associated with an increased risk of gynecologic cancers. And we found that their rates of preventative mastectomies are increasing. This has been going on for some time. And while we can't say for certain why that is, we can suspect that it has to do with increased knowledge regarding genes. So we're finding genes that are putting women at increased risk for breast cancer. We're finding new ones. There's greater patient awareness. And there's events like this that allow patients to feel empowered and educate themselves on as to breast cancer risk. And there's also an increased access to breast reconstruction across the country. Now, when it comes to this, I think of patient awareness of reconstruction after mastectomy as a before and after May 2013, because in May 2013, this woman, Angelina Jolie, publicized that she had undergone a bilateral mastectomy for risk reduction with implant reconstruction. And this really obviously generated a lot of buzz. And also, I think when you think of a woman whose appearance and whose breasts play a larger role in her life than they do for most other women, can go ahead and do this. I think many women in the community at large felt empowered. So there's a lot of decisions that need to be made, and some of these are difficult and involve complex choices. There's a lot of data that relates to preventative mastectomy, and it can really be difficult to parse and process. One of the good things about breast cancer is that we have a lot of data about it, but it can really make decision-making very complicated, and even for us, it's hard to keep track of. So these decisions really should be made in consultation with experts in breast cancer risk. They're specifically expert at that, and that could be your breast oncologic surgeon, you could be your breast medical oncologist, or a geneticist that has specific training and experience with this particular risk, geneticist or genetic counselor. So finally, we're getting to the plastic surgery aspect of things, the reconstructive consult. There's going to be a lot that's thrown at the patient at this time. The consult is appropriate even if the patient's not ready to proceed. I do these a lot, and while they're not always the highest yield, and I think of them a little bit as information sessions, I think it's a lot to think about, and you can sort of start getting the process percolating. There's really a ton of options, and it can be really overwhelming. I encourage patients to write down their questions and to bring somebody with them that can help them remember things and sort of advocate for them. And it's okay to remember, this is really complicated. It took me 10 years to learn what all the options are, and I don't expect the patient to be able to figure that out in 45 minutes to an hour. And it's important to remember that breast reconstruction is about empowering the patient. You know, a lot of women have guilt associated with this, but I think it's important to remember that wanting to have breasts is not vain. Women are generally used to seeing themselves with breasts starting from age 12, 13, something like that. And by the time they've reached their 30s and 40s, this is sort of imprinted in their self-image. And I think it's very traumatic to lose that. The consult should be centered around the patient's goals, and the patient should feel confident to openly share their goals, their concerns, and their preconceptions with their plastic surgeon. And I think it's also important to encourage the patient to be educated. And we all know that this is a double-edged sword because the information that you find can be sometimes misleading. But I always find that an educated patient is a happy patient. And then I, as the plastic surgeon, need to learn a lot about you at this consult. I need to know all sorts of things about you, ranging from the mundane, such as your age and other medical problems, to things that are specific to breast reconstruction, such as your breast size, your shape, your body type. Oh, Epic wants me to upgrade. What previous surgeries you've had. What do you do for a living? Are you able to miss a significant amount of time from work? What lifestyle issues are there? And what are the activities that are important to you that we don't want to harm when performing breast reconstruction? And then I think the next important part is setting expectations and what the goals of the reconstruction is. So, you know, some of these things that I say come straight out of sort of my spiel that I give to patients. And, you know, I talk to patients about 3 goals of reconstruction, and the first 2 should be readily achievable, barring a complication. And the third takes time, and takes time and work, both on my part and on the patient's part, because some of it is psychological. And the first goal is that in clothing, nobody should know. Women, you know, pretty much every woman does not want this to be a conversation starter with strangers asking them what's going on with her breasts. And second goal is that I want my patients to be comfortable looking at themselves. We can't have a situation where a woman is taking her clothes off to go take a shower and is avoiding the mirror because she's horrified to look at herself. And then the third goal, and this takes time, as I mentioned, is being comfortable with somebody else seeing their breasts, somebody else touching their breasts, and things like sex and intimacy. And again, in terms of setting expectations, it's important to remember the reconstructed breasts will never look exactly the same as native breasts. Whether they will look better, worse, indifferent is sort of multifactorial and also subjective. So I think that I try not to get into that because that's a judgment call. But ultimately, it's important to remember the breast will not look exactly the same. And the last thing that's important to remember is that for the optimal aesthetic outcome, and this is variable from woman to woman from woman to woman as to how important this is to them, the optimal aesthetic outcome will almost certainly require additional revisions, so additional small surgeries. So while a lot of these reconstructions are presented as single stage reconstructions, they almost all require small touch-ups. All right, so when I talk to women about options for mastectomy reconstruction, I tell them right off the bat that I'm going to oversimplify things because otherwise we're just going to drown in information. So let's go ahead and simplify things and find X. And the oversimplification is that there are implants-based reconstruction and tissue-based reconstruction. And choosing between the two will require taking into account patients' goals as well as the reality of their specific situation in terms of medical conditions, body types, and lifestyle issues. So implant reconstruction, there it is. There's the breast implant, usually done either in 1 or 2 operations. Sometimes the temporary implant is placed, followed by replacement with a permanent implant. Implants are either saline or silicone. Again, without getting into it too much, I strongly favor silicone implants. I'm happy to discuss that with anybody that has specific questions as to that. And then the important thing to remember is that we do not use textured implants or the solid implants, the so-called gummy bear implants. Those have been associated with a rare type of lymphoma. And actually, Yale was at the forefront of banning these implants even before the FDA acted. So what are the advantages of using implants for reconstruction? It's a shorter operation and a shorter recovery time. It does not add a ton of surgery to the mastectomy that you're already having. And basically it's volume on demand. So the implants come off the shelves in a variety of sizes and we can pick sizes based on that. There are disadvantages. The biggest disadvantage, I think, is that it's not always the most natural looking or feeling reconstruction. It's not the same as putting in a breast implant for cosmetic surgery where the implant sits under the breast. Here, the implant is essentially sitting under the skin, and particularly when nude, it's fairly obvious that it's a breast mount in most cases rather than a true breast. Implants are likely to have a problem that requires them to be replaced at some point in time that's going to come into play during the woman's lifetime. I tell women an average of 15 years or so. And then there's an entity called breast implant illness, or BII. This is, there are women that report that they feel like they've been harmed by their implants. They report a variety of symptoms that are sort of non-specific. And while I don't know for sure that implants are actually causing these symptoms, I don't think these women are crazy. They're feeling what it is that they're feeling. And we don't know for sure that it's not the implants. So it's something to keep in mind. So just some examples, and you know, as I warned you, we're gonna be seeing some breasts. This is a woman in her 20s who underwent preventative mastectomy and then a reconstruction with temporary implants followed by permanent implants and a nipple-sparing mastectomy. And this is her outcome about a month after her implant exchange. A fairly good outcome with reasonable volume and shape. This is a woman, and you'll see the blue squares when I've blocked out potentially identifying tattoos. This is another woman, very slight, in her 20s, with very good breast aesthetics that wanted a single stage reconstruction. So she had her preventative mastectomy, again, nipple sparing, followed by an implant that was placed at the same time of the mastectomy. And then just our last example, this is one more woman that was done. This was more recent. I wonder if we can see her COVID mask in one of these pictures. And she also had a single stage reconstruction with an implant. And as you can see, these are all very good results, very aesthetic results, but they do not look exactly the same as their native breasts. And then there's tissue reconstruction, and for full disclosure, this is my preferred method of reconstruction for most women. It's a preferred operation. It's a much more interesting operation. I think it's a better and more lasting result. There are several options, but the majority of the time we take tissue from the lower abdomen. it's a much bigger operation in recovery. And the way I've presented to women is to think of it as a larger upfront investment for what may be a longer term result. So again, advantages, there's no implant, there's no foreign body, and some women are really disturbed by that idea. It doesn't require the upkeep or replacement of an implant. And study after study shows that in the long run, women tend to be more satisfied with tissue reconstruction than implant reconstruction. There are disadvantages. It's a much bigger surgery and a much more significant recovery. And as I say to women, you're having surgery somewhere where you don't need to. There's nothing wrong with your belly. You do need to have surgery on your breasts. It doesn't necessarily mean we have to make an incision on your belly. And like I said, the most common form of tissue reconstruction is the DIEP flap, which is tissue taken from the belly, similar incision to a tummy tuck. Blood vessels are taken with the tissue, dissected through the muscle, and then hooked up to blood vessels in the chest to allow that tissue to replace the filling in some of the skin of the breast. Some examples, this is a woman, again, just going to the fact that this is a preventative mastectomy. It gives us time, there's no rush. So she wanted preservation of her nipples. She obviously has large breasts that have some sag related to breastfeeding. And what we did here is we did a breast reduction followed by a mastectomy and a deflap. And this is her shortly after her reconstruction. You can see she has a small wound on the left that ended up healing. And you can see the scar across her belly, but this is a reconstruction with her own tissues. This is another woman in a similar result. She's in her 40s. She's breastfed multiple children, and she has sagging of the breasts. She is, however, quite thin. And what we did here is we did a breast lift. At the time of the breast lift, Dr. Elena Ratner, who's our GYN oncologist extraordinaire, did a GYN gynecologic risk-reducing surgery. And then we came back and did reconstruction with tissue from her belly and nipple preservation. Women come in all different shapes and sizes. This is a woman in her late 20s. She carries some extra weight. She did not wish to have her nipples preserved. She was concerned about any breast tissue that may be left behind in her nipple, and therefore she had nipple sacrifice with her mastectomy, and she wanted to be upsized. And this is her early result. Obviously, we'll want to tweak her belly a little bit, but overall, her aesthetic result of her breast reconstruction is very good. And then again, a more recent example, this is a woman that had a mastectomy and immediate reconstruction with tissue from her belly. At that same time, Dr. Ratner did laparoscopic surgery to reduce some of her gynecologic cancer risks. And this is her early result. Those are not her native nipples or nipple reconstructions. She likes to use paste-on nipples, and she's comfortable with that, did not wish to have any further surgery. So I'll yield my time since we're running out of time. Some take-home messages. I know I just ran through a lot, and this is a brief period of time to take in all this information. So take-home messages, it's never too early to get your information and start your due diligence and to educate yourself. Breast reconstruction is a right for all insured women, and this includes Medicare and Medicaid as codified by federal law. This is not a one-size-fits-all type of operation. Therefore, it's important to work with a team that can offer all possible types of reconstruction. Breast reconstruction is a pretty significant physical and emotional investment. This is not something that's we're gonna wave a wand and everything's gonna be perfect right away. And the optimal reconstruction may require several stages. And then, I was trying to figure out what the best way to put this was. And I guess the take home is that it doesn't matter what anybody thinks. It's the woman and the patient that dictates the role that their breasts play in their lives. And it's my job as a reconstructive surgeon to facilitate these decisions. So this is it. I'll give it over to the next speaker, and I'll be happy to answer any questions at the end.
All right, so I think you'll need to, there we go.
I'll start sharing here. you're doing that. Okay. Wait, are those, okay. Is that your slides or my slides?
Those are your slides, Dr. Farrell. You should be able to navigate through them, unless you'd prefer to pull them up yourself.
No, that's great. We'll fire ahead. Thanks very much. Again, thanks very much to the organizers for for putting these sessions together. It's kind of in this new era. You know, I've been asked to talk about pancreatic cancer, the risks and surveillance. My name is James Farrell. I'm a gastroenterologist, predominantly, and kind of with an interest in pancreatic disease. And obviously the overlap with hereditary breast and ovarian cancer syndromes is the reasons I get to to work in this very interesting, exciting world of genetic risks. So, so I can't advance. That's the only thing. So if I go to my own slides, let me just pull up my own slides, right? Because I can't click to start.
Try now, Dr. Farrell. I think I just gave you control.
No.
No?
You know, let me, is this me or is this you?
Nope, that's me. But if you do start from
yeah,
beginning,
let me try and pull up my
to...
own. Let me just try and pull up my own slides. Otherwise, I won't be able to advance.
Okay.
Let me just try. If not, we'll go back. We'll try that. We'll do share, and we will go to. How's that? Okay. So, you know, pancreatic cancer compared to a lot of other cancers is not as common. And when you look at numbers in terms of kind of estimated rates for all cancers, it's actually low down on the list, like number 9 and number 10 for men and women. But when you look at cancer-related deaths, it jumps up to number 4. And for 2020, there's a rising number of about 56,000 cases or so, and an equally large number of deaths due to the kind of the nature of the disease. And it's estimated that by 2025, which is rapidly approaching, but at least 2030, pancreatic cancer will be the second most common cause for cancer-related deaths. It might even be the first. And this is due to a variety of issues, for sure, progress with other diseases and other types of cancers, but also kind of the slow incremental progress that's been made, or the slower incremental progress that's been made with pancreatic cancer treatment, as well as early detection. So this is a patient with this is a CAT scan, and this area, I can just tell you here in the center is a pancreatic cancer at a very early stage. The liver is over here, and I can tell you there was no evidence of any disease in the liver. And also these white structures here are major large blood vessels, and the tumor is away from that. And so this is a patient who has a surgically resectable pancreatic cancer. This is a patient also with a mass in the head of the pancreas, and it's very close to this blood vessel. This is a major blood vessel in the area. So a surgeon typically would not be able to surgically resect this without having to take a blood vessel. So this is what's called locally advanced disease. And this is pancreatic cancer where the disease has spread outside the pancreas. And now we're dealing with disease lining the lining of the belly or the peritoneum. So this is metastatic disease. And when you look at pancreatic cancer in terms of site of presentation, unfortunately, the number of patients, or the percentage of patients who present at that early surgically resectable stage is kind of at an optimistic 15%. And those patients do better, they do well, with a median survival in the region of 20 to 25 months. But unfortunately, the vast majority of patients are presenting either at that locally advanced stage, where a surgeon can't resect, or at a metastatic stage where the disease has spread to the liver or beyond. And so removing the primary pancreas does not make biological sense. So despite some of these late presentations and realizing that the vast majority of patients do currently still present at a late stage and require medical treatment with chemotherapy or sometimes radiation therapy, there have been advances. And so one of the studies that has been that has pushed this field along occurred about 10 years ago, where a new regimen of drugs called FOLFIRINOX was found to be vastly superior to the existing drugs, gemcitabine. And this has really kind of sparked a lot of new interest in this area, but there's still a long way to go. And again, the vast majority of patients still succumb to the disease even after chemotherapy and even after surgery, unfortunately. So there's many reasons for why the prognosis with pancreatic cancer is poor and why a lot of the patients will present at late stage. And some of it has to do with the very non-specific symptoms associated with the disease. Here's just a list of the more common one. And if you look at them like abdominal pain, weight loss, anorexia, nausea, vomiting, depression, back pain, these are very common non-specific abdominal pain. They don't have to be pancreatic cancer. Jaundice is also, and the turning yellow is also a very common presentation, but there's many explanations for that, as well as the darkening of urine. Two other presenting symptoms that are just kind of worth noticing, and we'll come back to the diabetes, but include acute pancreatitis. This is a patient who presented with acute pancreatitis, and so pancreatitis is inflammation in the pancreas, typically associated with gallstones or alcohol use. And this patient presented in December of 2015, and everything basically settled down. When they came for a reevaluation of their pancreas several months later, their pancreas was perfectly normal, even by the best imaging we had. There was no hint of anything going on. And that was February 2016. And then the patient presented back in November 2018, so well over 2 years later, with a pancreatic ductal adenocarcinoma. So what we surmised from this, that there was something going on back in this early stage in 2015 to 2016, but just beyond the limitations of our imaging to kind of pick up what was going on. And so acute pancreatitis as a presentation can't be ignored. And when patients are followed who have acute pancreatitis and matched with the individuals who don't have pancreatitis, there is an increased risk of an underlying pancreatic cancer, which we have to keep in mind. So specifically related to pancreatic cancer screening, and most people are familiar with the terminology of screening as it relates to even breast cancer screening or even colon cancer screening. For pancreas cancer screening, the issues are quite difficult and quite challenging. People have defined a successful screening program as the ability to detect and treat very early, small, resectable pancreatic cancer at an asymptomatic stage, or the ability to find precancerous lesions. They have names called PANNs or IPMNs, which I'll come back to. And this is a very high challenge for pancreatic cancer screening. Now, a lot has been found out about pancreatic cancer over the last 10 or 15 years. It is an incredibly studied disease. And we know about the sequence. So we understand a lot about the sequence from the normal pancreas through a variety of stages leading to pancreatic ductal adenocarcinoma. Sometimes people will often ask when people present with pancreatic cancer, well, how long was it there? Like, when did this actually show up? And could I have found it earlier if I had a scan? And the reality is that when it goes from an early to a metastatic or locally advanced or metastatic stage, it's probably of the order of 1 to 1.5 years. It's a relatively short time frame when it presents as an invasive cancer. The more interesting aspect of it is that there is some information that tells us that for a pancreatic cancer to develop from a perfectly normal pancreas through precancerous stages and then to pancreatic cancer can take up to 11 years. And what that means to me is that it provides a very large opportunity for intervening and trying to find these cancers or precancers at an early stage. Now, unfortunately, a lot of the precancers that we see with pancreatic ductal adenocarcinoma are not clearly visible with a standard CT scan or an MRI scan. But there is a subgroup of precancerous lesions which are, and these are what are called pancreatic cysts or fluid collections. And it's guesstimated that they contribute to about 1/4 of all pancreatic cancers. Now, pancreatic cysts are very common and are guesstimated to occur in about 6 million people in the entire US population. They typically are found on CT scans done for other reasons. So individuals might have a kidney stone, for example, and then end up having a CT scan to look for the kidney stone. And lo and behold, we find this in this particular situation, a 2-centimeter cyst, a fluid collection in the pancreas. The image down below is a more extreme version where there's multiple cysts throughout the pancreas, but cysts are very, very common. And clearly, the vast majority of cysts that are found do not develop into cancer, but some of them do. And a lot of work has been done into trying figuring out which patients we should be more aggressive with and which patients we can follow. The other issues relating to pancreatic cancer are issues that are modifiable risk factors that include exogenous factors that are related to the development of pancreatic cancer. Most of them you're probably familiar with, including things like tobacco. There is a small cigarette smoking. There's a small risk associated with alcohol use. H. pylori infection of the stomach and some viral hepatitis have been associated with that. Through a mechanism of inflammation, obesity is also a risk factor for pancreatic cancer, as it is for a variety of other cancers. We've already mentioned pancreatitis, or inflammation of the pancreas. And then we'll come back to this issue of diabetes and the risk of how diabetes plays. Let me just finish up that, how diabetes plays a role in the development of pancreatic cancer. There are some things that we have very little influence on in terms of inherited risk. And these are the non-modifiable risk factors, including genetic syndromes and family history, which I'll also come back to. So diabetes and pancreatic cancer is a very complex subject. Diabetes is quite common. And for sure, diabetes can increase the risk of developing pancreatic cancer. So that factor has been well established. But it's also now appreciated that pancreatic cancer in itself can result in diabetes and affect blood sugar. And so diabetes can in fact be a presentation for pancreatic cancer. It is a very complex area, and there's a lot of combined and shared risk factors like obesity and insulin resistance and age and so on and so forth. And we're still teasing apart a lot of it. A fairly large study that was done several years back of 512 newly diagnosed pancreatic ductal adenocarcinoma patients showed that somewhere about 85% of all patients had some form of elevated fasting blood glucose. Some of them met American Diabetic Association criteria for new onset diabetes. And others also had long-lasting as well-established diabetes, and others had kind of what we call pre-diabetes. But overall, about 85% of all patients presenting with pancreatic ductal adenocarcinoma had some fasting blood glucose abnormality. To tease this out a little bit further, people have actually gone back and noticed that blood sugars begin to rise about 36 months before the visibility of pancreatic ductal adenocarcinoma in the pancreas. So there's something going on in the pancreas at a very, very early stage that results in the blood glucose rising and the body's inability to control it, presenting ultimately in some form of diabetes. People often ask about why don't we have a blood marker for pancreatic cancer, and it's not for lack of trying. In fact, there's a variety of ongoing studies and potentially available blood markers that are out there for a simple blood test for pancreatic cancer. This is one such marker that we are actually currently, one set of markers that we're currently evaluating. But the real challenge is how these markers or these blood tests behave in the general population. And this is one of the reasons why we don't do currently general population screening for pancreatic cancer like we do for colon cancer or breast cancer. And it's just that the way our tests are designed, and due to the relatively low prevalence of the disease compared to these other diseases, it would result in what are called a lot of false positives, so that the test would be positive, but the vast majority of patients with a positive blood test would in fact not turn out to have cancer or pancreatic cancer specifically. And so we have to get better at managing this. So there's a lot of knowledge about what could go into a good blood test, but the problem is how do we deal with that positive blood test and avoid a lot of these false positive tests? And the real approach to this in 2020 has been to focus on high-risk groups. We've talked about pancreatic cysts, and we've talked about diabetes. And just for the remaining of the talk, I want to talk about familial pancreatic ductal adenocarcinoma, which makes up about 10% of all presentations for pancreatic ductal adenocarcinoma. If you go ask about family history, if you go looking for hereditary syndromes or looking for a germline mutation in the blood, you'll find some hereditary susceptibility to pancreatic cancer. Now, a lot relates to how many first-degree relatives you have, and the greater the number of first-degree relatives you have with pancreatic ductal adenocarcinoma, the increased relative risk, going from about 4.6 if you've got one first-degree relative, all the way up to about a 32 increased relative risk if you have 3 first-degree relatives. Normally, I would ask people to identify those individuals, and I could, tell you that this is President Carter and his brother Billy, I believe was his name. And the Carter family is kind of one of the more well-known families that had at least 8 or 9 relatives, all with pancreatic cancer. No identifiable gene was found. President Carter, to the best of our knowledge, never had pancreatic cancer, which he attributes to not smoking. But interesting, when we look at these large families, the most common abnormality or germline mutation that's found, but it's only found up the order of like 20%, depending on which group you're looking at, is the BRCA2 mutation. So still the majority of patients that have a familial pancreatic cancer risk, we do not have a clearly identifiable a germline or blood test or mutation that we can look for. So these are the familial syndromes that are associated with pancreatic cancer. With respect to kind of the focus of these sessions, BRCA1, but especially BRCA2, PALB2 and ATM are really the most common germline abnormalities that we find. There are a variety of other abnormalities such as Peutz-Jeghers, hereditary non-polyposis colon cancer with abnormalities in the mismatch repair genes. There's a series of genes that are associated with hereditary pancreatitis, which results in recurrent attacks of acute pancreatitis. There's a very high-risk gene called a P16 mutation, as well as the APC mutation. But as I said to you before, for a lot of patients with familial pancreatic cancer, where we know that it runs in the families, but we just don't have a germline or an identifiable gene in that family. So in 2020, these are the lists of individuals that we would offer pancreatic cancer surveillance to. We typically are doing it as part of a research protocol, but you could actually get this as part of standard of care for clinical practice. That has implications for insurance coverage, but we would prefer and strongly recommend individuals do it as part of a research protocol. And we have a variety of research protocols that are open at Yale. The groups that we are primarily interested in are really just coming from the prior table, include patients with Peutz-Jeghers syndrome, familial pancreatic cancer individuals. So again, anybody over the age of 55 with at least 2 first-degree relatives with pancreatic cancer. Any individual with one of those germline mutations, and we do think about high-risk germline mutations like BRCA2, PALB2, and ATM, but also the other germline mutations such as BRCA1 and HNPCC. And then that final group of hereditary pancreatitis, which is a less common entity, but is associated with an inherited predisposition to getting recurrent attacks of pancreatitis. As of about a month ago, we are following about 127 patients. I think we're now up to about 140. Again, a large number of these do not have any demonstrable germline abnormality that they've inherited. And as you can see, the breakdown there is as we've alluded to already. This is one of the interesting things that goes on when we study these individuals. All these individuals get a combination of MRIs of their pancreas, as well as an endoscopic ultrasound, which is a very high resolution imaging study of the pancreas, and then obviously biopsying anything that's concerning or suspicious to us. Research studies in the past have collected pancreatic juice from these individuals, and when some of these individuals have gone on to develop pancreatic cancer, we're able to go back and look at pancreatic juice from several years, anywhere from 4 to 61 months prior to the presentation of that cancer, when the patient's imaging was perfectly normal, and find some abnormal DNA mutations suggestive of an early tumor. And so the hope is that that might be one strategy for further surveying and selecting out individuals at risk for developing pancreatic cancer. One of the issues that comes up all the time is, what effect does this have on outcome? Does this actually improve our ability to detect pancreatic cancer early and improve the overall outcome of these individuals? And this data is really just beginning to accrue, because this work has really only been going on for about the last 10 years. And now we're beginning to see long-term survival studies. This is one large study that looked at pancreatic ductal adenocarcinoma diagnosed during an active surveillance program, and stage for stage was associated with an improved survival compared to individuals presenting from a symptomatic perspective. So some promising information that perhaps surveillance is going to improve overall survival for pancreatic ductal adenocarcinoma. So to summarize then, we don't do general population screening like we would do for colon cancer or even for breast cancer per se. We tend to focus on high-risk individuals, particularly looking at high-risk individuals with germline mutations or familial risks. And those individuals get a combination of MRIs of their pancreas as well as an endoscopic ultrasound. And then it's done on an annual or biannual basis. And we're beginning to accrue data about the benefits of this approach. Pancreatic cysts I mentioned only because they are incredibly common, but do give us an opportunity to visualize these pre-cancerous lesions in a subgroup of individuals. And diabetes is an area of incredible interest right now as another subgroup, particularly new onset diabetes, in individuals at the age of 50 and above, that may represent an opportunity to find pancreatic cancer early. Finally, just a brief plug for, with the help of Claire and Amy and her colleagues in the cancer prevention group here at Yale, we've set up a dedicated pancreatic cancer early detection clinic where we see patients with these sorts of concerns to see whether they're eligible for high-risk surveillance or to counsel them about their risk with relation to pancreatic cancer. So on that note, I'll thank you. So I have to, so I'm going to get out of here. So your screen stops sharing. That's me. Okay.
Oops. Claire, I'm pulling up Dr. Farrell's slides. I'm going to click them.
Yours are in there. Okay.
Oh, I think I clicked out. Do you mind trying again?
That's fine. Nope. Amy, you might need to bring them up on your screen if you can.
Sure. Okay, is everyone able to see that? If you're on mute, you can just nod. Okay, great. So good evening, everyone. My name is Amy Killey. I am a licensed and certified genetic counselor from the Smilow Cancer Genetics and Prevention Program, and I will be presenting a talk that I call Yes, Men Too, Screening for Men with Hereditary Breast and Ovarian Cancer Syndrome. Just as a caveat, this is only discussing men who are cisgender, not men who are transgender. Cisgender would be men who are assigned male at birth. Transgender are men who are assigned female at birth. So just because it's also where all the information is. So let's dive in. When we talk about hereditary breast and ovarian cancer, sometimes the first thing we think about is women. This is something that can only impact women. But what's actually the case is that hereditary breast and ovarian cancer have cancer risks for women and men. So just to review, when we talk about hereditary cancer, anyone who attended the talk 2 weeks ago about the overview of hereditary breast and ovarian cancer syndrome, this might look familiar to you, but most cancer that's diagnosed is not hereditary. Most of it is we call sporadic, so due to random chance, aging, the environment. But in some families, we can see red flags for hereditary cancer, such as cancer diagnosed at much early ages, such as breast cancer or colon cancer diagnosed under the age of 50. We can see multiple relatives in one family with the same type of cancer, like relatives all with breast cancer, for example. Rare cancers, such as ovarian cancer, pancreatic cancer, or male breast cancer. Unusually aggressive cancer, such as prostate cancer that has spread or metastasized in different parts of the body. One person having multiple different types of cancer. And we know that Ashkenazi or Eastern European Jewish individuals have a higher likelihood of having hereditary breast and ovarian cancer syndrome. So you may ask, what causes hereditary cancer? What causes hereditary breast and ovarian cancer syndrome? So if you see this, and that's a gene, we have what we call cancer prevention genes in all the cells of our body. We all have these genes. So when we talk about hereditary breast and ovarian cancer, we're really talking about someone that is born with an inherited mutation in that gene, which is a harmful change that makes that gene not work correctly. And someone who is born or has inherited this mutation has an increased risk of developing certain types of cancers. So really it is from this single genetic predisposition, this single gene mutation, that we can see multiple cancer risks from one inherited cancer predisposition. So when I think about hereditary breast and ovarian cancer, I really just think of it as almost an umbrella term. It is not only related to breast and ovarian cancer risk, it's related to multiple other cancer risks, including female breast cancer, male breast cancer, pancreatic cancer, melanoma, ovarian cancer, and prostate cancer. And you can see these are cancers that can impact men. One also thing that's important to know is sometimes that there is an understanding that only women can inherit hereditary breast and ovarian cancer risk, or only women can pass on this risk to their children. But we know that men and women can pass on as well as inherit hereditary cancer risk or single gene mutations. Because when someone has a child, we pass on half of our genes to both of our sons as well as to our daughters. So knowing someone's family history could be very important to know whether or not someone should have genetic testing and whether or not they could be at risk of having a hereditary predisposition, whether you're a man or a woman. Looking at the whole family history can have impacts. So let's talk about the specific cancers that we can see in men. So one that we can see is male breast cancer. As an overview, male breast cancer is quite rare. It makes up only about 1% of all breast cancer that's diagnosed. It impacts 1 out of 833 men. Just as a comparison, breast cancer in women impacts about 1 in 8 women. So we can see breast cancer in men is much less common. We do see a slightly higher prevalence of male breast cancer in African American men when we compare to other ethnicities, such as Caucasians, Hispanics, and as well as Pacific Islanders. We see a risk of male breast cancer as men get older. The average age of diagnosis is about 68 years old, a little bit older than the average age of diagnosis in women. The average age for women to be diagnosed with breast cancer is about 62. What we also notice about male breast cancer is that it is more often diagnosed at a later stage than with breast cancer in women. And when I say later stage, I mean that it may be diagnosed with a larger tumor size. The cancer may have involved the lymph nodes and possibly have metastases, meaning that it's spread to other parts of the body, such as the bones or the brain or the lungs. The reason for this is not quite clear. It's possible that given its rarity, there may be less of a general awareness among men, and also, of course, for men in the general population, there's no annual screening that is recommended as is for women in the general population with their annual mammograms. And male breast cancer and female breast cancer appear biologically to be similar, but there may be some pathological differences. As an example, one study suggests that male breast cancer is exclusively hormone receptor positive. So what that means is that hormones in the body like estrogen and progesterone that men and women have, that in breast cancer in men, these hormones almost exclusively the tumor depends on these hormones to grow. Hormone receptor positive breast cancer is the more common breast cancer in women, but we can sometimes see in women a hormone receptor negative breast cancer. Clearly, more research is needed given that it is a more rare cancer type. What we know also about male breast cancer is a family history of either female or male breast cancer may impact a man's risk of developing breast cancer himself. So the risk could be up to 2.5 times that of a general population if a man has a family history of breast cancer. And this risk may increase if a man has multiple relatives with breast cancer, particularly breast cancer that's early onset, meaning under the age of 50. And that could possibly increase a man's risk 5 times that. Again, 5 times 1 out of 833. Interestingly, about 20% of men with breast cancer have a first-degree relative with breast cancer. So whether that's a man's mother, his sister, his father. So there is clearly a familial component. So unsurprisingly, when we talk about hereditary breast cancer in men, which again is caused by that single gene mutation, we know there are some studies that suggest that inherited gene mutations can explain 4 or up to 40% of all male breast cancer. Of course, you can see this is quite a range, and as research can be contradictory, but as clearly seeing male breast cancer alone in a family indicates genetic testing, because it does increase the risk of a hereditary predisposition. So the 2 genes we're going to hear a lot about tonight are the ones that are the most well studied and are the most well associated with hereditary breast and ovarian cancer, as well as risk for men. They are the BRCA1 and the BRCA2 genes, more colloquially called the BRCA genes. Men with a BRCA1 mutation have between a 1 to 5% lifetime risk to develop male breast cancer, and men with a BRCA2 mutation have a 5 to 10% lifetime risk to develop male breast cancer. BRCA2, I would say, is the big one for men. The risk for men and their different types of cancer is higher than that with BRCA1. So even though most men with a BRCA mutation will not develop breast cancer, there is a significantly increased risk when compared to that general population risk. Again, that 1 out of 833 approximately. There are other breast cancer genes that can possibly cause a risk of breast cancer in men. Those risks aren't well defined. We still need more studies. There's another high risk gene that's called PALB2 that's related to high risk for breast cancer in women, and 2 moderate risk breast cancer genes called CHEK2 and ATM that possibly could have a role for breast cancer in men. So when we talk about the screening, again, I'm going to be mainly talking about screening for men with BRCA1 and BRCA2 mutations, because that's where most of our data and our guidelines are. But based on the National Comprehensive Cancer Network, or we call NCCN, it's where we get the majority of our screening guidelines, men are recommended at age 35 to begin breast self-exam training and education. So that could be just being aware of their chest wall, noticing any lumps, bumps, changes in the nipple, redness of the nipple, any scaly skin on the nipple or nipple discharge, and then bringing that to their doctor. And then having an annual clinical breast exam with their primary care provider at age 35, again, to look for any changes in the breast tissue or chest wall. At this point in time, the NCCN guidelines does not recommend mammography screening for men unless they have gynecomastia, which is men who have enlarged breast tissue. And that would be recommended at age 50 or 10 years younger than the earliest male breast cancer diagnosis in the family, whichever comes first. There have been a couple more recent studies that have been screening men without gynecomastia that have a BRCA1 or BRCA2 mutation. And some of that data does suggest that mammograms may be helpful in that population. So, but at this point in time, only annual mammograms are recommended for men with gynecomastia, but stay tuned. And this is just an image of a man with a BRCA2 mutation who underwent an annual mammogram. The next big cancer we would talk about is prostate cancer. So prostate cancer worldwide is the 2nd most common cancer in men. It is very common, and it is approximately the 5th leading cause of cancer-related death worldwide. 1 in 9 men will be diagnosed with prostate cancer, so it's a very common cancer in men. It is more often seen in men who are African American, And men who are African American may also be diagnosed with a more aggressive type of prostate cancer when compared to other men who are white or Hispanic. And we also see increasing age can be a risk factor for prostate cancer. The average age of diagnosis for prostate cancer is around age 66. Most of prostate cancer is what we call indolent, meaning that it may be asymptomatic. If it is diagnosed, it may only need routine screening surveillance closely in the beginning. It may not require a lot of treatment or surgery. However, prostate cancer rarely can be aggressive. What's used to grade the aggressiveness of prostate cancer is called the Gleason score. And when we see a Gleason score of at least 7 or more, it indicates a more aggressive prostate cancer. So when we see a man with a Gleason score 7 prostate cancer, especially if he has other family history of breast cancer, prostate cancer, ovarian cancer, we can think maybe there is some hereditary predisposition. And particularly metastatic prostate cancer in and of itself alone does increase suspicion that there is a hereditary risk. In fact, one study found that 11.8% of all metastatic prostate cancer patients that were tested had a single genetic or inherited mutation, which was significantly higher than men who had what we call more localized prostate cancer, meaning it had not spread to other parts of the body. And again, with BRCA1 and BRCA2, BRCA1, the risk is less well described, but possibly between 17 to 23% risk over the lifetime. And BRCA2, the risk is higher. As I mentioned, BRCA2 is between BRCA1 and BRCA2. BRCA2 is the one that has higher risks for men. The lifetime risk could be between 23 to 67% lifetime risk. What we may also see with men with a BRCA1 or 2 mutation is that, particularly BRCA2, they may be diagnosed under the age of 65. And as we talked about, the average age for prostate cancer diagnosis is 66. So we may see it at younger than expected ages. There are other hereditary cancer genes related to breast cancer that may have a risk of prostate cancer. However, that risk is either not clear, or if there is a risk, it's not well defined. These are 2 genes I mentioned earlier, 2 moderate risk breast cancer genes called ATM and CHEK2. And there are other genes that are related to hereditary prostate cancer that actually aren't related to hereditary breast and ovarian cancer at all. So that's why it is important for people to be discussing their family histories of cancer. Now, prostate cancer screening for men with BRCA1 and BRCA2 mutations. NCCN guidelines suggest that when men are 40 years old, that they begin having an annual prostate-specific antigen, or we call PSA blood test, as well as a digital rectal exam. The rectal exam is to manually examine the prostate to see if there's any abnormalities, and the PSA blood test is used to see if there's any increasing levels. PSA is antigen that's secreted by normal prostate tissue as well as prostate cancer. So the thinking is that if PSA is rising or is high, it may indicate a prostate cancer. But neither of these tests are diagnostic. They are screening tests. There could be other explanations for why there's an elevated PSA. The only way to diagnose the prostate cancer is through a prostate biopsy. And it's just an image of a man getting a PSA blood test. So really these screening tests beginning at a younger age are used to help detect prostate cancer at a much earlier and treatable stage. Pancreatic cancer. I'm not going to go into too much detail with this because I'm following Dr. Farrell, who did an excellent job, but just to put in my 2 cents. So Dr. Farrell talked about BRCA2 mutations, which again, BRCA2, the lifetime risk for pancreatic cancer is between 4 to 8%. BRCA1 mutations, the risk appears to be elevated, but that exact risk is not well defined. It is significantly impacted by family history of pancreatic cancer. So most individuals with BRCA1 and BRCA2 mutations will not develop pancreatic cancer. However, if there is a family history, as Dr. Farrell discussed, those with a BRCA1 or BRCA2 mutation would be recommended to consider high-risk pancreas screening as part of a research protocol. And additionally, these are other 2 genes Dr. Farrell mentioned. These are 2 genes related to hereditary breast cancer, ATM and PALB2. So when we have an individual with a BRCA1 or 2 mutation, PALB2 or ATM, and a family history of pancreatic cancer, screening can be considered beginning at age 50 or 10 years younger than the earliest pancreatic cancer diagnosis in the family. And finally, melanoma. So melanoma is the least common type of skin cancer, but it does have a higher mortality rate. And it has been increasing in incidence. From 2001 to 2010, it has increased by 1.6% worldwide. And even though it's the least common skin cancer that we would see, it makes up about 73% of all skin cancer related deaths. And 1 in 63 individuals in the United States will develop melanoma. And the majority of melanomas are on the skin, though melanoma can develop in rare places, such as the eye. Over 91% of melanomas are, we call cutaneous, on the skin. But the second most common would be of the eye, called ocular melanoma, though that is also rare. The biggest risk factors for melanoma in the general population are fair skin, sun exposure, blistering sunburns, and tanning bed use. Particularly fair skin, the incidence of melanoma in Caucasians is about 2.3%. The risk for African American men is 0.1 in the men and women, and the risk for Hispanic men and women is about 0.5%. So fair skin is a big risk factor for melanoma. What we know about BRCA1 and BRCA2 is that there appears to be a higher risk of melanoma, but really that risk is not well defined. There has been a small associated risk of ocular melanoma in individuals with BRCA2 mutations. This has not been really seen in individuals with BRCA1 mutations. At this point in time, with the other hereditary breast and ovarian cancer genes, there's not a strong association with melanoma. CHEK2 is a moderate risk breast cancer gene that I mentioned that some studies have suggested melanoma, but really it's not very strong association with other hereditary breast or ovarian cancer genes. So what does NCCN recommend for men and women screening for melanoma? So there's no specific guidelines that exist, partially because the risk appears to be relatively low and is not well defined, but general melanoma risk management is appropriate. So that would be an annual total body skin exam by a dermatologist. So to look over the whole body, to look for any abnormal moles, and of course, a person being aware of any changes to any moles that are getting bigger, getting darker, having any uneven borders, and bringing that to their dermatologist. And of course, avoiding excessive UV exposures, wearing a hat, using over SPF 50 sunblock, and avoiding tanning beds. And for men with a BRCA2 mutation, they may consider an eye exam by an ophthalmologist, as the goal is, again, there's a small risk of ocular melanoma, but this type of exam will be used to look in the back of the eye to see if ocular melanoma ever did develop, that it was caught much earlier. So just as a summary, hereditary breast and ovarian cancer syndrome has distinct cancer risks for men, not just women. There are cancer risks for men, and there are management recommendations for men who have a hereditary breast and ovarian cancer syndrome. And the whole point of screening and management recommendations is to either prevent cancer or detect it at a much earlier treatable stage. And I would recommend to learn about your family history. Family history can really impact screening recommendations like the pancreatic cancer screening, and also can really learn more about if other genetic testing is indicated, and to also inform other members of your family. So thank you everyone for attending. If you have any questions or comments, feel free to hang out at the end and send me a question, or if any questions come up later, you can contact me at our program's email and ask away. Thank you.
All right, thank you everybody. So we have had a couple of questions come in, but if the attendees want to send some more, that would be great. So Dr. Avraham, we had one question come in. The individual asked, if someone is slim, is there always enough tissue in the stomach area to perform a DEEP?
So there's a short answer and a long answer, and the short answer is that no. Obviously, even some of the examples that I showed, these were women that were very slim. They have never been pregnant. They don't have any excess tissue in their lower abdomen. The good news is that if a woman is committed to reconstruction using her own tissues, adamant against having implants, there are usually other options. My primary go-to for secondary option is the inner thighs, for example, because just the way women tend to be shaped, a lot of women carry, even that are very thin, carry some extra weight on their inner thighs, and that's an opportunity to leverage that for breast reconstruction. There's tissue in the back, there's tissue in the buttock. So the answer is that it's complicated, and that it requires a more thorough discussion, and we're almost always able to find tissue for a tissue-based reconstruction for a woman that's committed to it.
Great, thank you. And Amy, we had a question come in that says, if you already have prostate cancer, is it ever too late to get the genetic testing?
No, if you already have prostate cancer, it is not too late to get the genetic testing. There are a couple of benefits to individuals who have prostate cancer to have genetic testing. One is that men with more advanced prostate cancer or metastatic prostate cancer with a BRCA1 or 2 mutation may be eligible for specific therapies that are more targeted to their cancer type, so it can be benefit for their treatment. And additionally, this is also added giving information to the family. So someone with a cancer diagnosis who does have genetic testing can then provide information to their relatives to know if they need to have their own genetic testing so they can be aware of their own cancer screening management if necessary.
Great. And then another question for you, Amy. Is there a certain age that you recommend men or boys from families with a known BRCA mutation pursue genetic testing?
Great question. So we do not test men who are under the age of 18. The youngest we would ever test is someone who's 18 because they are a legal adult. That being said, men with a BRCA1 or BRCA2 mutation, we would not even begin their cancer screening until they were 35 with annual clinical breast exams. So it's completely reasonable for men to wait until they're closer to that age when cancer screening might change their management if they were BRCA positive at that time. Of course, some men who are younger want to know for any family planning and things like that. But of course, some, especially younger men, there is some considerations for getting life insurance in place prior to genetic testing if people have concerns about that. So I would say, I was a little long-winded, but at least 18, completely reasonable to wait until 35, and also definitely reasonable if a man younger than 35 wanted to have testing that was motivated, especially for any family planning.
All right. And Dr. Avraham, what's the recovery period like after reconstruction?
Talk about a loaded question. So it's really variable. I tell women, and it's hard to couch. So I try to couch it in terms of time missed from work, which is also not perfect because some women don't work, and women also have different types of jobs. Obviously, somebody that works as in construction would have longer time out of work than somebody that has a desk job. But I tell women that have a mastectomy without reconstruction to expect 3 to 4 weeks out of work. Women that have mastectomy with an implant reconstruction, a similar time out of work, and women that have mastectomy with tissue-based reconstruction, more like 4 to 6 weeks out of work.
Thank you. And Amy, maybe you can answer this question. If you had genetic testing earlier, say maybe around 2002, and had a BRCA mutation identified, is it worth doing genetic testing again, just to sort of look at maybe some of those other genes to see if there's another mutation in a different gene?
Great question. It would, I would say, depend on your family history. So if the BRCA2 mutation that was identified in 2002, if that is tracking in the family, meaning that we're finding it in everyone in your family who had breast cancer, ovarian cancer, pancreatic cancer, additional genetic testing is likely to have low yield because that's the most likely explanation for why we're seeing cancer in your family. However, if in the past 18 years, there's been a different diagnosis of breast cancer, another cancer that's not related to BRCA2, or maybe there's cancer history on both sides of the family, so it's unclear, maybe the BRCA2 mutation was inherited from your dad, but there's family history on your mom's side, it might be reasonable to make an appointment to at least do an assessment with a genetic counselor to determine if additional genetic testing would be indicated.
Great, thank you. And Dr. Farrell, should all patients who have a family history of pancreatic cancer get genetic testing?
No, not all family members. So because, sporadic pancreatic cancer is still the more common type when you go looking for it. Number one, probably makes up about 90%. And even for individuals where we think there's some sort of familial link, we still don't understand all the genetics of it. In fact, there's probably shared environmental, either microbiome issues at play that affect someone's risk. So it involves kind of having the discussion, looking at the risk factors, but the typical scenario is at least 2 first-degree relatives related to each other who have pancreatic cancer, and then your relation with them as a first-degree relative would make you at increased risk for familial pancreatic cancer. And so those would be the individuals that we would typically ask for and look for. But we also kind of are interested in, if there is a history of young pancreatic cancer, that's always kind of alarming when someone presents in the age of 30 or 40, because it's typically a disease that starts at the age of 60 and above. Although strictly by guidelines, we don't follow it, but it certainly kind of concerns me when I hear about young pancreatic cancers in families. And then for small families where there might not be easy to understand, or the history might not always be complete to understand if certain relatives had pancreatic cancer, or in olden times when it was just some sort of intra-abdominal tumor, we keep that in mind as well. And then, thinking about are there other cancers in the family that would push towards getting someone to have cancer genetic testing, such as breast cancer, prostate cancer, ovarian cancer. So it's multifactorial in the decision making, but strictly speaking, it should be at least 2 family members for that. Although we just add and kind of also add that, per recent guidelines, as people are familiar, people with a newly diagnosed pancreatic cancer, so these are patients who have it, are being recommended to have some form of germline testing, not just because it has treatment implications, but also because around the flip side, it has implications for familial risk of pancreatic cancer.
All right, great.
I will also say, sorry, just to add on that, I will say that NCCN guidelines that I quoted a lot, they do recommend that individuals who have a first-degree relative with pancreatic cancer, even if there's no other family history, do consider genetic testing. So even though having one first-degree relative, as Dr. Farrell mentioned, may not qualify you for high-risk pancreas screening, it may qualify you for genetic testing.
Great, thanks, Amy. I think that's the last of the questions. So thank you to all of our speakers. This was a great evening, and it was great to have everybody attend. Have a good rest of your night.